I want to thank you for sharing this time with me. I'm Calvin Chao, the Vice President of our Global Medical Affairs in Exact Sciences, formerly from Genomic Health. I've been working with this company now for 12 years and lead our Global Medical Affairs function. I've had the opportunity to work on a number of products. For the longest, it has been on the breast product, but also on colon cancer and prostate cancer. So our prostate cancer test is what I'm talking about today, the Genomic prostate score. And I'd like to spend a little time to discuss our background evidence, the validation data, but really provide you some updated information that we have on the GPS. I will also spend a little bit of time talking about GPS and MRI, as well as spend a little time talking about the multi-gene genomic assays in general, and a comparison of the data that we have with GPS with the two other leading tests, Prolaris and Decipher. So thank you again for spending some time here. And let's go ahead and move on. I'd like to start off with really a wonderful quote that comes from a physician who's a legacy in the area of urologic oncology. Willett Whitmore from the Memorial Sloan Kettering Institution once phrased the dilemma. Is cure of prostate cancer possible when it's necessary, and is cure necessary when it's possible? So really, I think this was a very foretelling quote that he made really back in the middle of the 20th century. And he had a very long career of 40 years and eventually developed prostate cancer himself at the age of 74, at which time he elected for active surveillance. So really he practiced what he preached. I think that we really have a disease here where we all understand that patients who actually are potential candidates for active surveillance really do overall have a very, very good outcome. So on the left, this is from the PROTECT trial. We all know that patients who received surgery and radiotherapy fared no different than patients who had active monitoring in that trial. And yet, if you look at on the right side, there was, however, some evidence of disease progression, metastasis, or death from prostate cancer for the active monitoring group that certainly by 10 years approached 15 to 20%. So that certainly raises concern, and we need to really understand who is likely to do well and who is likely to have this disease progression. The NCCN guidelines has recognized that for low and favorable intermediate risk patients, in fact, those who have life expectancy over 10 years, you can see that molecular testing of the tumor is now recognized as a legitimate test that is adding value to help us work up these patients. And in fact, the GPS assay is included in these NCCN guidelines. And likewise, the NCCN guideline framework for risk assessment is also integrated into our GPS test reporting. So for patients who have clinically low risk and favorable intermediate risk, the GPS test may be a consideration. I think what's very unique about the GPS test and what's very important about, and a point that I'll raise again and again, is that the outcome of adverse pathology at radical prostatectomy is a very immediate and actionable endpoint. It's a very important surrogate marker that is at a proximal time point, an immediate time point, when you're trying to make this decision for a patient based on a core biopsy, where we certainly are interested in who is likely to eventually have death and metastasis from prostate cancer, but these are very, very distant events, and they're very, very low rates of events. In fact, they're really quite, it's almost like looking for the needle in the haystack. If you start out with low or favorable intermediate risk patients, so few patients have death from the disease and relatively few patients with metastasis eventually. But on the other hand, it is the chance that the patient may be harboring some adverse pathology within their prostate gland that should you take the patient to surgery, you may find that the patient actually has a higher risk pathology than you think, or perhaps some extra prostatic disease. So our GPS test is really the only test that has been very well validated in the right populations of patients based on the core biopsy material in low and favorable intermediate risk patients. And I think this study from the Mayo Clinic is a nice illustration, and there certainly are many, many data sets that show that a biopsy is really imperfect in really assessing what the radical prostatectomy specimen may show. In this series, which is actually very recent from the Mayo Clinic, published in 2017, you can see that when patients present with Gleason 6 or a Gleason 3+4 pattern on biopsy, you can see that there are substantial rates of misclassification when found at prostatectomy. So for those that are 3+3, you can see that 20% of the time the patients harbored a 3+4, 3% more than this 3+4, so it could be a 4+3 or more, or 6% of the patients have non-organ confined pathology. Likewise, when patients are presenting with a 3+4 biopsy, 22% of the time it can be downgraded to only a Gleason 6. So, you know, the 3+4 may have been a false finding on biopsy. And then also, as well, we can see 12% and 17% being upgraded either in higher Gleason patterns or non-organ confined disease. So really, this doesn't give us enough confidence to make a decision if you only have the core biopsy and traditional pathology. And just to illustrate why it is so bad to have adverse pathology detected, we can see that from an aggregate of data from a number of studies, those patients who have adverse pathology found, defined as 4+3 or greater Gleason pattern, and or any extra prostatic disease, we see that they have very high rates of prostate cancer mortality, metastasis, or biochemical recurrence. Really only about half of the patients are progression free, or less than half. On the other hand, if we are assured that the patient most likely does not have adverse pathology, if we know that patients have either a Gleason 3+3 or at most a 3+4, we can see that 92% of the time we are having progression-free survival outcomes, and only a very small fraction have the very concerning events of metastasis or death. So one of the points that I think is important about the GPS test is in how this test was developed. That really assessed the possibility that there might be heterogeneity and multifocality within the prostate cancer presentation. So in fact, when the GPS test was selected for its genes, you see that 727 genes were initial candidates, but this was then brought down to 288 genes, which were then assessed in a cohort of patients that had actually different patterns, higher pattern of Gleason pattern 4 or more, and the lower pattern of 3 that might have been the primary dominant pattern. So most of these were 3+4 type patients. And we know that prostate cancer is a very heterogeneous multifocal disease. And so what was done was that the developers deliberately took samples from the highest pattern of 4 and the dominant pattern of 3. And from those two different regions of the prostate, they selected only those genes that actually expressed uniformly across those two different areas. And therefore, uniformly and also were correlating with the risk of disease progression and metastasis. So the types of genes that were selected were ones that did not have disparate expressions across the phenotypically different patterns. They were uniformly expressed. Therefore, the genes that we ended up with are ones that are not so influenced by the Gleason pattern itself. They have similar expressions and they all correlated with risk. This is what we did to try to mitigate the risk of the effect of heterogeneity and multifocality. Now, that is not to say that we actually validated it for this purpose. I think we have to be careful about overemphasizing this point, but I do think it's an important point to understand that the genes you see, those 17 genes that were selected, were ones that passed this test of development, where only those genes that uniformly expressed across the two different patterns of Gleason scores were selected and included as candidates for the final gene set. So eventually, we actually selected genes that represented 4 different biologic pathways: androgen signaling, cellular organization. These 2 pathways are very important for representing better outcomes in prostate cancer. And in fact, the androgen signaling set of genes is really quite important because we know this is an androgen-driven disease, and the higher the expression of these genes, the better the outcome for the patient. It's a better prognosis. And then the other 2 groups, the stromal response and cellular proliferation, represent genes that are associated with worse outcomes. And then, of course, there are 5 reference genes. And here you see on the right, you see the odds ratios for these different individual genes and gene groups. And I think that the fact is that this assay does represent multiple different dimensions of biology that are all important. It's very complex, cancer biology, and it's important to be able to represent all of those different features within the molecular aspects of the tumor. It is not just a proliferation assay, for example, that Prolaris is. So I think that's quite an important point of differentiation between the GPS test and Prolaris, in that their test only represents proliferation and ours has a variety of different biologies represented. So 17 genes are included here with a score between 0 and 100. This test, GPS, has now been very, very well validated. And you can see in the middle group, the 4 key studies that were done. And you can see the makeup of the patients in the blue bars. Most of these patients are the very exact types of patients that you would consider an active surveillance program for, right? So we are only interested in patients who are truly active surveillance candidates, not patients who might be at a much higher risk. And I think this is another thing that differentiates the tests. You have to develop the test and validate it in the population you want to be managing for the question of active surveillance. If you want to predict metastasis and death for other reasons, for example, in high-risk patients for whom you want to treat differently, that's a different clinical question, and you would need to do different validation for that. But the endpoints that we see here, importantly, include adverse pathology, biochemical recurrence, metastasis, and death. In addition, there are a number of clinical utility studies now performed. You can see the variety of these on the right, and I'll run through a few of these, but this also shows that the test works in real life in guiding and managing patients' decisions. So the validation study that was done at UCSF and through the US military called the CPDR represent the 2 cohorts that are ending up on the report for GPS to assist you with that estimate for the risk of adverse pathology, the likelihood of finding 4+3 or greater, or the likelihood of finding extraprostatic disease. So you'll notice that we contextualize the score depending on the NCCN risk group, very low, low, and intermediate risk groups. And you can see that for each NCCN risk group at the baseline, there is a spectrum of different risks of adverse pathology as correlated with the GPS score down at the bottom. Certainly for patients who have low risk, you'll see that in these data points where the GPS is high, many of these patients have very high risks of adverse pathology, just as if they had intermediate risk NCCN risk classification. Likewise, there are some intermediate risk patients who have low GPS scores. Those below 20, in fact, do quite well and have risk levels that are maybe more commensurate with low or very low risk patients. And so this is really an important ability to help define that very question. If I'm to take this patient to surgery, what's the likelihood that I would find adverse pathology that is otherwise not showing up on this biopsy? In addition, we do offer also the projections of 10-year risks of metastasis and death as seen here. And, as you would expect, this cohort of patients, which is from Kaiser Permanente, looked at a number of patients that admittedly are higher risk. So this is not just confined to the patients who are active surveillance candidates, but also includes some high risk and some intermediate risk patients who clearly are worse off and you would treat. I think that, and I'll make this point again later in the program, metastasis and death is something that the patient loves to hear. Am I likely to die from prostate cancer? Am I likely to have metastasis from my prostate cancer? And the likelihood, frankly, is in most active surveillance candidates, thankfully, the risk is pretty low. But I think that, for reasons of offering that reassurance, we're likely to show these low numbers to any patient who is really that active surveillance candidate. And, but I think from a very practical point of view, it's the adverse pathology risk that's much more differentiating in your patient who is low risk or favorable intermediate risk. We really need to understand that because, this risk of metastasis and death is really much more relevant when you have clinically higher risk patients. And this is something that I think, again, as we consider why all the tests offer this, that is why I think to offer that kind of reassurance to most patients. But it's adverse pathology that's really going to be important from a practical standpoint. So of one point you should know is that for patients who have very low and intermediate risk, no patients with a GPS less than 20 in the Kaiser study had metastasis or died from prostate cancer within 10 years. So I think that's a reassuring point. If your score is less than 20, that's very good for the patient and a very strong encouragement that the patient may not need active treatment. So this is what you see on the report. And you can see that the score is represented along with the NCCN risk group classification that they end up with, right? So we potentially can reclassify the patient in terms of what their risk group might be. And you can see the actual score, and you get the endpoints of prostate cancer death, which is often very, very low, in this case less than 1%, metastasis risk in 10 years, 2%, and adverse pathology risk, which is what we think is going to be the more important actionable feature of the outcome. And the adverse pathology is broken up on page 2 into the high-grade disease risk and then non-organ confined disease risk. Again, based off the validation data that we have, we also offer a bell curve to show where this particular patient lies in their original NCCN risk group. So this patient started off with a low risk NCCN, and he is at the high end of that range of patients who may not necessarily want to elect active surveillance if they feel that a 49% risk of adverse pathology, right? That's a 50-50 chance of having some kind of adverse pathology in their prostate. So this is how we want to make this very relevant and have a good conversation with the patient based on a number and a figure that's very actionable. So as Oncotype is the only test that has been validated across all these different endpoints, importantly, adverse pathology, but also the components individually of adverse pathology, of non-organ confined disease and high-grade disease, as well as biochemical recurrence from the Kaiser study, metastasis and death. We think that this is actually presenting the utility of something that the patient and the physician can talk about and help guide their decision for active surveillance decisions. The other tests, as I'll show you shortly, are now attempting to give you more of these earlier endpoints, but I think without the same level of rigor and quality of data, and we'll get to that shortly. In terms of reclassification, you can see that this is from our commercial experience. So 12,800 patients with an NCCN low risk, you can see how they end up getting redistributed to different risk categories. So many of these patients end up very low risk, so that this is for a great reassurance to the patient. 38% stay low risk, and then 15.5% go up into the favorable intermediate, and then smaller fractions actually go further into the unfavorable intermediate or high risk, very small chance there. So in general, what we can say is that a low risk is most of the time pretty good for the patient, but there might be about up to 20% of the time where we do have to be a little bit concerned that maybe we're thinking about considering a higher risk patient than we expect based on the pathology. The NCCN intermediate risk group, now these are only favorable intermediate risk patients that even get the test. So you can see that the redistribution here, most of them stay in the intermediate risk range. Actually, the purple represents the unfavorable intermediate. So it's only a smaller fraction of favorable intermediate risk overall that are really good candidates for active surveillance. So you see the 15.8% shift lower to a low risk, and 7.6% stay at the favorable intermediate risk. So we would argue that these are the patients, about a quarter of them, might be good candidates for active surveillance. Notice that some of the patients go even higher. So they go 18% go to high risk. So I think this favorable intermediate risk classification is a widely heterogeneous group of patients. Some of them are good candidates for active surveillance, but a lot of them are not. And you can see now that in our practical clinical utility data, these are each different study that has been done looking at active surveillance rates. These are all studies that have been done over the last several years. You can see that the rates go from about 40 to 50% without the GPS test to upwards of 60 to 70 or 80% with the GPS test. Overall, increasing active surveillance rates by about 24% on average in low-risk prostate cancer. We also have some good data from a insurance payer. You can see that based on electronic health records and claims analysis over 3 years, that the rates of active surveillance without GPS was on the order of 60% at 6 months, increasing to 90% with GPS. And at 12 months, there is a persistence of the active surveillance with the GPS group. So not only are patients electing active surveillance a year out, they have stayed on active surveillance most of the time. So this is a 30% absolute increase in active surveillance rates. So now I'm going to shift to some additional data that does not appear on the report, but I think it might be relevant as they are newer data sets. One of the criticisms that we receive is that, well, that's wonderful, GPS, you predicted active surveillance, but in patients who all had radical prostatectomies. That is true. And that is something that I think is always going to be a tricky, challenging limitation. But I think what has been very helpful is that Peter Carroll from UCSF offered to look at his real life experience with his active surveillance cohort of patients at that institution. And you can see that the GPS score this time was analyzed in patients who went on active surveillance. So there's 1,600 patients that went on active surveillance and then meeting criteria and then undergoing a later radical prostatectomy, delayed. So it's not immediately that they chose surgery, but they actually went on active surveillance and then at a later time, they had surgery. So there's 378 patients there, of which 215 had enough tissue for a GPS score for a confirmatory or diagnostic or confirmatory biopsy. And you can see the characteristics of the patients here, that these are very much representative of a good active surveillance cohort. 72% had Gleason 6, 28% had Gleason 3+4. And so we can see how did the results show at UCSF. We find that the GPS for every 5 units was statistically significant in a multivariate analysis of this GPS with other clinical pathologic features with a highly significant p-value. where there's about a 16% elevation in risk for every 5 units of the score for adverse pathology risk. As well, for biochemical recurrence, you can see that there was about a 10% elevation of risk for every 5 units of GPS. This was significant beyond the CAPRA score. So the CAPRA is what UCSF uses instead of NCCN risk classification. In fact, the CAPRA did not perform in terms of statistical significance in this multivariate analysis. I should mention also that PSA density was only marginally significant. It missed the clinical significance threshold for adverse pathology and was not significant for predicting biochemical recurrence. So we'll talk a little bit about PSA density again in another study where I think this is a small controversy that has arisen from the Canary study, which I'll tell you about shortly. So the UCSF experience was also important in looking at MRI performance in the same context as GPS. So separately, Peter Carroll had looked at patients who had GPS and also had MRI. So here, these are patients who had lower intermediate risk CAPRA scores and other clinical features that are consistent with active surveillance candidacy. And they underwent multiple biopsies, and they had GPS testing, multiparametric MRI with PIRADS version 2 or both. And you can see what they looked at was the biopsy upgrade as the primary outcome from a 3+3 to a 3+4 or greater. And what they found was that the GPS was associated with an increase in the upgrade at the later time point of a confirmatory biopsy. So for every 5 units, there was about a 28% chance of an upgrade in that pathology. So the MRI PIRADS for a score of 5 or 4, those were also associated with the upgrade, but not a PIRADS 3. And when you look together at GPS and the MRI PIRADS, only the GPS was an independent predictor of that upgrade. So now let me get to a study that has been recently published and presented. Dan Lin from the Canary cohort of patients, they also have an active surveillance cohort, which we studied. Tissue blocks were from 2008 to 16 from 8 different sites, and an active surveillance was strictly followed where we actually assessed the tumor tissues on the core biopsies and assessed whether or not the GPS was associated with adverse pathology at a delayed radical prostatectomy time point, similar to what I just showed you from the UCSF experience. They also looked at the issue of upgrading in this cohort. I think what should be noted is that this is a very, very low risk population who obviously these are patients who already were pre-selecting active surveillance. So I think what's important to know is that, you know, when we ask the question, is GPS helpful to you to predict who should go on active surveillance and who should have surgery or treatment? That is actually an ideal cohort of patients would be ones where, you know, before you actually, you have a group of patients where you haven't made the decision yet. Then you actually assess those tissues in the core biopsies, and then you can see, okay, now how much can I predict the outcome in those patients? That's a very, very difficult study to perform because you know, we only know adverse pathology if you do the surgery. So it's actually quite challenging. So here, what we have is a group of patients who have already picked active surveillance. So naturally, they're already low risk. And we are now following them and looking at the patients at a later time point when they do have surgery to see, you know, what the findings are. So you'll notice that the Gleason grade group 1, the 3+3s represented 92% of the patients, and 45% of the patients were very low NCCN risk group, 39% low, and very small numbers were intermediate. Notice that a good number of patients either had no diagnostic biopsy tissue available, 234, and 174 had insufficient tumor on the biopsy. And so we couldn't analyze because there was so little tumor on the biopsy scores were not done or were not available. So overall, you know, this is really a very good prognostic group and a very low event rate. So this is what I think the major challenge was in the CANARY study. If you look at the primary endpoint, this first model showed that the GPS was indeed associated with adverse pathology, where every 5 units was associated with an 18% elevation of risk. Very similar to Peter Carroll's UCSF data. This was statistically significant when done factoring in controlling for the Gleason grade group 2 versus 1. In the second model, you can see that the GPS slightly missed the statistical significance threshold, 0.066. And you can see that here, the log PSA density was in fact statistically significant when Gleason grade group was also factored in. Now, there were only 52 patients that had adverse pathology, so this was a small data set. And in fact, the pre-specified protocol called for 65 events for adequate power. So essentially, this result trended towards significance, but it was not significant for GPS. We think mainly because this was an underpowered analysis. They were not able to get enough events. Now, additional context can be noted when you look at the very same study presented earlier at the ASCO GU 2019. So in that particular poster, the GPS in the second model, you can see was statistically significant with a 0.046 p-value, this time when it was just assessed with PSA density in conjunction with GPS without the Gleason pattern. So, you know, I think this is really very esoteric. It is something that I think points to the challenge that we have in a very, very good risk cohort in patients at a delayed time point. You know, you can argue if GPS really, it's approaching a marginal borderline significance in correlating with that adverse pathology at that delayed time point. But I think that is not exactly what the test was intended for. The test was intended for predicting adverse pathology at the time of surgery if done at that time. So, you know, again, we all wish we had the ultimate best cohort of patients to study. Those patients have to date not been available. And just to remind you, in that larger UCSF study, a different outcome was achieved where GPS this time was significant, highly statistically significant at that delayed time point of adverse pathology assessment, and log PSA density in his study was the one that didn't quite come out as significant. So I think that, you know, we have two different studies with slightly different outcomes, and you have heard my interpretation. Now I'd like to switch to MRI. So MRI is a useful tool. It is a good assessment of anatomy and the presence of larger volume tumors, definitely. We actually believe that this is nicely complementing what the GPS score can offer, which measures the tumor biology. And in fact, I think good literature exists on the performance of MRI. We certainly know that MRI does detect more clinically significant cancers and less clinically insignificant cancers, and requires fewer biopsy cores when used as a means of directing your biopsy approach. But this particular first reference that is in European Urology 2019 is a very, very good meta-analysis and systematic review of the literature, which I highly recommend. In that particular study, it was noted that 13% was the proportion of clinically significant cancers missed by an MRI-directed biopsy. So they were found on systematic biopsy, but not on MRI-directed. So it still can miss some of these important tumors. Similarly, I think that if a patient has a small volume tumor, less than 0.5 milliliters, many of these Gleason 4+3 tumors or greater were also missed. So that's a lot of patients, 75% of patients who have these more serious small volume tumors were also missed by MRI, but then later found on whole mount pathology. So I think, you know, MRI is definitely useful, but there are limitations. And I think the third limitation obviously is the inter and intra-observer variability, which I think has been well documented and summarized in a review article here. So in real life, I think that Laurie Klotz from Canada has noted the potential limitations of MRI in the very patients that you would be thinking about active surveillance. So for those patients who are Gleason 3+3, 273 patients, you can see that he compared confirmatory biopsies by MRI, targeted approach, with systematic biopsy and systematic biopsy alone. And you can see that both methods actually had comparable outcomes of about 30% upgrading to higher Gleason patterns. So in his view, the MRI targeted biopsy did not necessarily increase the upgrading rate compared to systematic biopsy in the Gleason 3+3 patients who were the active surveillance patients in the ASSIST trial. Other data from the UCLA group noted that the MRI actually can miss a good proportion of patients. We've already talked about 3+3, but let's talk about the 3+4, where you can see in this 588 patient cohort, a good 40% of the patients actually had missed tumors in the MRI assessment. And even in 4+3, about a quarter of the tumors are missed there. So again, MRI is helpful, but it's not always perfect in being able to find all the important aggressive tumors that we are concerned about. And in fact, the ASCO guidelines does recognize that both MRI and genomics may offer complementary independent information. So these tests, as they say, may provide information independent of routine clinical parameters and independent of one another. And so this is their bottom line recommendation as published in the JCO in 2019. We actually have some data, again, this is from the UCSF group, where Peter Carroll looked at patients who had negative and indeterminate and positive PIRADS scores, and then the GPS score. You can see that there's a fairly wide distribution of GPS scores, regardless of the MRI finding of negative or positive results. And then the UCLA group did further work on GPS and MRI, where patients who had both MRI and systematic guided biopsy were available for biopsy tissue analysis with GPS. And we studied the cohort of patients with 3+3 and 3+4. We see here that the GPS in a multivariate analysis was highly statistically significant for predicting adverse pathology, as well as the highest biopsy Gleason pattern. But in this particular analysis, the MRI PIRADS 2 to 3 versus 4 to 5 was not significant in predicting adverse pathology. And likewise, in a subgroup analysis of intermediate risk patients, the GPS was also highly statistically significant in predicting adverse pathology in favorable intermediate risk patients. Here we see actually the ROC curves in this UCLA study, where you can see that the highest PIRAD score alone had an AUC of only 0.57, GPS alone was 0.73, and GPS plus Gleason's pattern 0.79. And when you add the PIRAD to the GPS Gleason score, actually the AUC stays the same. So really, I think the GPS does add value here for predicting adverse pathology. Again, this is a useful tool to be added in addition to the MRI, should that be performed. What GPS represents is it's the only test that's been well validated as a predictor of adverse pathology in exactly the right patients who are active surveillance candidates, low and favorable intermediate risk patients. And adverse pathology is this important actionable endpoint that we need to help us predict who is likely to do well or not do well with active surveillance and risk of metastasis in the long run. GPS is complementary to MRI, and is something that, again, offers additional information in the context of MRI-directed biopsies. And in the US, we have fairly good coverage now. Medicare has been covering for many years, and many new private plans are offering the test. And so, I think this is something that we continue to work on very much with these different payer groups that, again, I think for active surveillance, this is really the test that is the best validated in the right patients. So with that, I would like to conclude and offer to take any questions you may have.
Thank you so much, Kelvin. We are open to questions, please.
I have a question.
Yes.
Hello. So my name is Ruben. I'm a fifth-year medical resident. I would like to ask you, let's say I have a patient that with ISO score 2, which I do a GPS score that comes, let's say 15, and I put him on active surveillance. And then I go and do a biopsy 1 year afterwards, and he still has an ISO rate score 2. So do I need to take another GPS score? So for how long does this score is valid if a patient is under surveillance for 5 years? Let's say?
Yeah, so I think
I need to repeat the score every time I do a biopsy?
Yes, I think one thing that we want to be very clear is that we don't have enough data that looks at the outcomes of patients who get multiple GPS tests. We're not really advocating at this time that patients should get repeated GPS tests because we don't have that data to date. Our data is very strong on that initial diagnostic core biopsy. So I would, I think that your following the patient and subsequent assessment by Gleason patterns and upgrading is, I think I would not necessarily offer to do additional GPS testings simply because we just don't have that outcomes data to interpret at this time. I think that frankly, patients who change their Gleason patterns, right? If you have an upgrading, this is something to watch closely. It is not something that I would, I would not necessarily go back to the GPS test. Does that help you?
Okay, thank you.
Other questions?
Yeah, I have a question, please.
Yes.
Okay, so Barak Rosenzweig from Shiva Medical Center. I'm a urologist. So the question is more of a concept, and I am aware of the validation cohorts that you mentioned, but it's more refers to the different location versus the prediction. Like it's a concept of biopsying a sample from one area, and then how do you explain that from a mechanistic point of view, that you're able to predict what happens in different areas that were not sampled at all?
Yes. So I think this is a matter of genotype versus phenotype. So we know that when you look at cancer cells, that there are some genes that express pretty similarly across all the different phenotypically different areas of prostate cancer. And this is because that when you think about the concept of truncal biology, as a tumor begins and as it evolves, there are certain genes that express uniformly. What eventually might differentiate into a Gleason 3 or a Gleason 4 in different parts of the prostate, indeed, there may be some genes who differentiate differently and have different genotypic expressions, but there are some genes that have the same expressions. So when you think about the trunk of a tree, that the truncal genes that have uniform same expressions across different Gleason patterns, that's what we did when we looked at the development of the test. We chose the genes that we believed were more representative of the stable truncal genes that express similarly across those two different Gleason patterns. There might be other genes. In fact, there are. We know there are other genes that also, as time goes on, they differentiate differently And they're more like different branches of the tree. So once you get out to the different branches, you might find some genes express high and other genes express low. We didn't pick those genes. We only picked the ones that are constantly stable in expression across the different areas.
Okay, so if I may continue for another question, is
Yes.
just when you refer to the Polaris test, you refer to the proliferation genes, and I was wondering whether you can place it as a group. I know it's, of course, might be imprecise, but can you correlate the proliferating genes to these truncal genes that you mentioned?
I think some of them, yes. I think that proliferation is important. But I think that proliferation may end up being a later phenomenon that I think, yeah, it's definitely important. And it's definitely correlating with risk of metastasis and death, for sure. But I think we're dealing with biology that sometimes in an early stage, low risk prostate cancer, there might be other genes that are actually more important than proliferation, like the androgen axis, or like the stromal interaction. I mean, there's a lot of other biology there that we want to be able to pick up. So I think that, again, proliferation is important, but it's not the only set of biology, it's not the only biology that we're worried about.
Thank you.
Any other questions?
Okay, Kelvin, if we don't have
Okay.
another question, so we will close now, and thank you so much.
Thank you very
I
much.
want to thank you all. I think this is a wonderful opportunity for me to see all of you on screen and to share some of this data with you. You can always email me through Lior, or we're always open to questions. And again, thank you again for spending this time with us. I appreciate your interest.